Hello, everyone. Good morning, good afternoon, and good evening. Thank you to all who are joining us live today and to those who are listening in afterwards. Welcome to another exciting digital event organized by the FIP. So today's event is part of FIP's series on vaccines and special risk groups. And today we'll be looking specifically at cardiovascular diseases. Next slide, please. So I'm your moderator today. I'm a pharmacist and a research fellow at the University of South Australia in Adelaide. So it's about 8:30 p.m. at night right now. And I'm also the immediate past president of the FIP Young Pharmacist Group. Next slide. So before we start, just a few housekeeping and announcements. So please note that this webinar is being recorded and it's live streamed via YouTube on FIP's YouTube channel. The recording will be available on our website at the events.fip.org. Please feel free at any time to pop in your questions if you have any questions using the chat box. Using the Q&A function. And feel free to, we also welcome feedback. If you have any, please send that through to webinars.fip.org. And finally, if you are not a member of FIP already, please join us at www.fip.org/membership_registration to enjoy many of our members-only benefits, as well as connect with a huge network of pharmacists and pharmaceutical scientists internationally. Oh yeah, one last point. We have language interpretation in French. So if you click the three dots on the top right, there's a language interpretation and you can pick French if you would prefer having an interpreter. We have a live interpreter, Elise, with us here today. Next slide. So FIP would like to acknowledge Sanofi for supporting this event through unrestricted funds. And without the support, this event and many other digital events would not have been possible. So thank you. Next slide. So we're really lucky to have a panel of experts in cardiology and immunization join us today. So we have Dr. Alvaro Sosa Liprandi, who's the president of the Inter-American Society of Cardiology from Argentina. Tolulope Ozikbisan, who's the Senior Policy and Advocacy Officer at the NCD Alliance in Switzerland, and Mr. John Rebenstein, who's the Director of Scientific Communications at Immunize.org in the US. And I'll give a brief introduction of each of our speaker and panelists in a minute. So this slide shows our program today. So I've now introduced kind of the structure of the day and our speaker and panelists. We'll start our session today with firstly a presentation by Dr. Alvaro on vaccination needs and benefits for people living with cardiovascular diseases, followed by a rich discussion with all the three panel members. As we go through the discussion and presentation, I'll also be looking at the Q&A chat box to see some of the questions from the audience. So feel free, your questions are really important to keep this session engaging. So please feel free to pop your questions in the Q&A box, and after that, we will close the session and I will head to bed. Next slide. So these are the learning objectives for today's event. So at the end of the event, we think participants would understand the risk that this particular population group, so people with cardiovascular diseases, is exposed to with regards to vaccine-preventable diseases, as well as the benefits of being vaccinated. I think you'll understand the main recommended vaccines for people living with cardiovascular diseases. And finally, we'll discuss some of the roles of pharmacists in supporting health literacy and vaccination of this special group. Next slide. I'll now introduce our speaker for our presentation, Dr. Alvaro Sosa Liprandi. So Dr. Liprandi is the president of the Inter-American Society of Cardiology in Argentina. He's the head of cardiology at Sanatorio Buenos Aires in Argentina, and he's also the director of Idea Medica Research and Education, and Director of Postgraduate Medical School in Cardiology in University of Buenos Aires. This is very challenging with the names, but welcome, Dr. Alvaro. Over to you. Alvaro, are you able to share slides? Thanks.
Okay. Okay, good morning. Good morning, good afternoon, everybody. Ladies and gentlemen, colleagues. It's really my pleasure to stay with you today. And thank you so much for this kind invitation and give me the opportunity to present my perspective about this very important topic. It's my intention in the next 20 minutes to present to you the close relationship between respiratory infection disease and the presence of cardiovascular events or cardiovascular mortality, and mainly discuss with you the important role of the vaccination as a very important cardiovascular prevention strategy. This is the agenda that I proposed to you this morning. Discuss the impact of respiratory infection, the role of the immunization, mainly discuss what about the guideline and our recommendation about the vaccination, and mainly a final point, very important to discuss, the barrier to the implementation of our recommendation. Just as an introduction, remember that when a patient is admitted to the hospital with a community pneumonia, there is a very number of conditions that can induce the presence of endothelial dysfunction, and after that, the presence of cardiovascular event like an acute myocardial infarction or a stroke. Some of these conditions are summarized in this slide: the presence of platelet activation, procoagulant state, systemic inflammation, and in the same time, coronary vasoconstriction, systemic vasodilatation, hypoxemia. All of these conditions, as I mentioned before, can induce the presence of endothelial dysfunction, and after that, it's possible to induce the presence of instability of one atheroma, the presence of thrombogenesis and the plaque rupture, and induce the presence of a cardiovascular event like an acute myocardial infarction or a stroke. When a patient is admitted to the hospital with a community-acquired pneumonia, the presence of cardiac complications are very high. This is a very classic paper published by Corrales Medina and colleagues that clearly express that when a patient is admitted to the hospital, the number of cardiovascular complications are near to 25%. And this kind of complication, including the presence of acute myocardial infarction, stroke, cardiac arrhythmias, and heart failures. Of course, there are many different, the vulnerable population are the present with the previous history of this kind of condition, and obviously the pre-existing comorbidities are the more important variables that the present the history of heart failure, cardiac arrhythmias, and coronary artery disease represent the more vulnerable population to present this kind of complication in the present of the cardiac pneumonia. If you look the same problem, but in a different angle, in a different point of view, for example, if you analyze the different registries of acute decompensated heart failure, you can observe that the principal cause of decompensation in patients with heart failure is the presence of one infection, and particularly the presence of a respiratory infection. This is the most important factor related with the decompensation of the patient with heart failure, with the previous heart failure, and it's more important than other conditions like hypertension, previous arrhythmia, or transgression with alimentation. these observations are very important because they have a very important prognosis implication. Look at, for example, that the present after when a patient is admitted, as I mentioned before, when the patient is admitted by a community pneumonia, the possibility of present a cardiac complication is very high, 4 times higher, for example, when you compare with other kind of patients. And they have a very important prognosis implication. For example, if a patient presents an acute myocardial infarction during a pneumonia, the mortality during the hospitalization or in the first 30 days is 4 times higher. Really very, very impressive. The presence of cardiac complication has a very important prognosis implication in a patient with pneumonia. And what about other kind of infection like influenza, for example? And influenza is clear a trigger of cardiac complication. There are many ecological and observational studies that reported that when you observe the peak of virus circulation, are a very close relationship with the peak of cardiac mortality related with acute myocardial infarction, for example. This is other very interesting observation that established the very close relationship between infection, respiratory infection, and the presence of acute coronary syndromes. This is very interesting observation by Dr. Wong and published in New England Journal of Medicine some years ago, that observed that when you have an infection related to influenza confirmed by laboratory, the probability of present an acute myocardial infarction in the first week is 6 times higher during this risk period when you compare with other control intervals. Really very impressive. And this kind of observation, this is another observation published, for example, by Warren Gash and colleagues that observed the same data. When you observe, when you have an infection for influenza, in the first week, in the first 3 days, for example, the probability of to present an acute myocardial infarction is 6-fold, 6 times higher, and the same observation is 1 stroke. This is very really impressive, the relationship, the very close relationship between the presence of respiratory infection disease and the presence of cardiovascular complication. And obviously, with the information, obviously the immunization are as a very important strategy in terms of prevention of cardiovascular disease or cardiovascular complication. What information we have about this point? This slide summarizes the results of one initial meta-analysis published by Hudel and colleagues that summarize the different clinical trials, prospective clinical trials, including randomized clinical trials that check the hypothesis of the importance of influenza vaccination in people with coronary artery disease. In this meta-analysis, as you can observe here, there is a clear reduction in the coronary events, in cardiovascular events, in the follow-up, in the first years, for example, in patients with coronary artery disease, when you compare patients who receive versus patients who don't receive influenza vaccination, there is a clear reduction near to 36%. One very interesting observation of this meta-analysis is that when you compare the reduction in cardiovascular event, when you compare the impact of the intervention in the acute phase versus the chronic phase, the impact of the intervention is higher during the acute phase. In acute coronary syndrome, for example, in acute myocardial infarction, when you compare acute coronary syndrome versus chronic condition, the reduction in the coronary events in the follow-up are near 55%, really very impressive reduction in the coronary events in the follow-up of these kind of patients when the intervention is prescribed during the acute phase of the acute coronary syndromes. Very important because express a big opportunity to present or to prescribe the vaccination, particularly in patients that are admitted to the hospital but are acute coronary syndromes. This is other meta-analysis published by Barnes and colleagues in Heart many years ago that clearly express the effectiveness of influenza vaccination in the prevention in acute of the acute myocardial infarction that is near to 30%. Very recently, in the past year, was presented the result of the Yami trial. The Yami trial really is a very important randomized, prospective randomized clinical trial that check in patients with acute coronary syndromes, particularly in acute myocardial infarction, in patients with acute myocardial infarction, that check the hypothesis if the vaccination can prevent the presence of cardiovascular event in the follow-up. They include this trial was stopped very early because the presence of the pandemic during the 2020, but in the trial it was possible to recruit 2,500 patients that was randomized to receive vaccine or no vaccine during the first 72 hours of the admission to the hospital by an acute myocardial infarction. And look at the results, very impressive results, near to 30% reduction in the primary endpoint, the presence in the follow-up of acute myocardial infarction, stroke, or the presence of stent thrombosis. Very, very impressive too. The authors perform an experimental meta-analysis, including the result of the Yami trial with the previous trial, including the trial published by Pharmaceutical and the Fluvax and Flucat trial, and look at, for example, in this exploratory meta-analysis, the reduction in cardiovascular mortality, including the total population, is near to 50%. Really very impressive too. This slide summarizes different intervention, different pharmacological intervention with proof efficacy in terms of reduction mortality after an acute myocardial infarction, and express the essential medicine that the patient need to receive after this condition, and including beta blockers, statins, ACE inhibitor, and aspirin. Remember that the more powerful strategy to reduce cardiovascular mortality after an acute myocardial infarction is the smoking cessation. But if you put in perspective the result of the influenza vaccination, look at that this intervention have a very similar, including higher results when you compare with other very classic intervention, like essential medication or smoking cessation. And this is the reason because we consider the influenza vaccination as a very important prevention, secondary prevention strategy in terms of prevention of cardiovascular event in the follow-up of our patients. What about other different conditions? For example, patient with heart failure, in patient with or without coronary artery disease. And in this case, you can observe here patient with the presence of heart failure, and you can observe here that the reduction in the admission to the hospital in the follow-up is near to 27% reduction in the people who receive immunization when you compare with people who don't receive it. And this is other interesting observation published by Dr. Modin and colleagues, and the result of the national high Danish cohort study, an important number of people with heart that when you rate over the time, you can observe at the same time a significant reduction in the cardiovascular mortality and the overall over time. That's in observational study. And this represents one very recent meta-analysis published by Rodriguez and colleagues that clearly expressed that the people clearly express that the people with heart failure, you can observe a significant reduction in cardiovascular event and cardiovascular mortality in people who receive vaccines. Very recently, we have the results of the Ibbe study, very important study presented by Dr. Loeb from McMaster University in the last American College of Cardiology this year. This represents a very important randomized trial in patients with heart failure. And when you compare, look at, for example, this trial includes 5,000 people that was prospectively randomized to receive or not influenza vaccination during 3 consecutive years. And you can observe here that the whole hospitalization was significant reduction. You can observe a significant reduction in all hospitalization, but in the global analysis of the trial, there are no impact in cardiovascular event in the total population. But when you compare the peak influenza period versus the non-peak influenza period, there is a significant reduction in the cardiovascular event when you compare people who receive versus people who don't receive influenza vaccination. And these results reinforce the idea of the necessity of the prescription of influenza vaccination in patients with heart failure. And finally, this is the last meta-analysis published by Zetlapati and colleagues that clearly observe in different clinical trials, in observational trials and in randomized clinical trials, there is a significant reduction in cardiovascular mortality in people who receive vaccination. What about other kind of vaccines like pneumococcal vaccines? This is a classic paper from Lamontagne and colleagues that clearly present that the people who receive vaccination for pneumococcal, for pneumococcal, can observe a reduction in the presence of acute myocardial infarction. And this is other interesting observation for Dr. Kuhn, published in many years ago. Is a trial performed in Hong Kong, and a significant number of patients, near to 40,000 people older than 65 with a history of previous cardiovascular disease, and compare what happened in people who don't receive vaccination, the people who receive both schemes of vaccination, pneumococcal and influenza, and the people who receive any kind of both. And you can observe here that the people who receive both schemes of vaccination have a better prognosis in terms of cardiovascular event in the follow-up, and really the reduction in ischemic heart disease, in acute myocardial infarction, heart failure, or admission to the CCU are very impressive in the people who receive simultaneously both schemes of vaccination, pneumococcal and influenza vaccines. Okay, this information is the reason because the majority of scientific society strongly recommend the prescription of vaccination in patients with a history of cardiovascular disease. But the question at that moment is that in base of this information, are the immunization strategy being applied in cardiology and particularly by cardiologists? Let me show you some example because the results in this point are very disappointed. This represent the results of the Paradigm trial. This is a trial in patients with heart failure with low ejection fraction that was included in a trial that checked the impact of other pharmacological strategy, but the investigators check in this population, in this multinational trial, the vaccination rate in different parts of the world, and look at the vaccination rate was extremely low in this kind of patient with heart failure with low ejection fraction. And the disparity in different countries all over the world are really very impressive. Look at, for example, in America, the rate goes from 0 to 70%. Similar research in Europe, tremendous disparity in different countries, and in Asia, particularly in Asia, the vaccination rate will get extremely low. And look at the most important predictors of the receipt of influenza vaccination is the country where the patient lives. Really very impressive. During the last pandemic of COVID-19, during 2020, we have the opportunity from the Inter-American Society of Cardiology to analyze what happened in our region in Latin America in 13 countries during the pandemic time. And look at, during this time, the vaccination rate for influenza and pneumococcal was less than 50%, with a great disparity between different countries. Look at in the South Cone, for example, in Argentina, Chile, and Paraguay, the vaccination rate was near to 70%, acceptable results. But look at in other tropical countries, for example, the vaccination rates were extremely low to near to 20–30%. And this introduces a very important point that is the barrier between our recommendation and what happened in the real world, and introduce the problem of the implementation. As you well know, there is a big gap between the information of the research and what happened in our real practice, in our real world. And we have a lot of very important barriers. And in the last part of the talk, I want to reinforce this concept because it's really very important that what we can do to transform our recommendation in action, because we have many different barriers to the application of the medical knowledge. And obviously the players are the doctors, are the patients, and between them, the health systems. What problem have the doctors, for example? And there are many different barriers related to the knowledge, the information, to the attitude of the external barriers. It's possible that the access to the information at the present time is very high. There is not represent the problem, but important point is the trust. Obviously, we need medical education program based in simple, reliable, and non-contradictory information. And it's very important that the guidelines and the recommendation should be adapted to locally and regionally. Obviously, the doctor have many other external barriers, like the care time, for example, but I want to stop in a very important point, that is the attitude of the doctors related to the immunization, and particularly in my case, the cardiologist. Because when you analyze the missed opportunities in vaccination, one of the most important topic is the missed opportunity is the not prescription of the vaccination at the time of the medical visit. And look at, this is a very important report from the CDC, the USA, that clearly explains this point. Because when the position of the patient is positive and position of the physician is positive related to the vaccination, the possibility of this patient receives vaccination is very high. But when the position of the physician is negative or indifferent, the probability of the patient receive vaccination is near to zero. This is a very important point. The conviction of the doctor is a very crucial point when you analyze the vaccination rate. What about the patients? The patients have problems, particularly with the trust, and it's very important to the awareness campaign, to make awareness campaign with simple, direct, and reliable information for patients and family. And in this point, our organization, the scientific society, have a big responsibility to perform this kind of campaign. This is one example, for example, in the last World Heart Day in September 29, when the Inter-American Society of Cardiology performed a very important campaign about the importance of the immunization, particularly in our region. Obviously, the patient have many other external barriers, the access, the cost, and the attitude. You know, the motivation, the depression are very important dimension related to the non-adherence to other recommendation. And what about the context? The context is very important. Include the vaccines as essential medicines is very important. But look at in our region, for example, in Latin America, only 36% of the countries are include these kind of vaccines as essential medication. Very recently, our Society of Cardiology presented this document, the consensus document related to the importance of the influenza vaccination, and express our commitment with this kind of intervention. And express in other aspect, we express the importance of the barrier. Remember, medical conviction is main determinant, and obviously there are a very important numbers of factors that are related with the hesitancy of the patients, related with cultural, geographic, economic, ethnic difference, where you can find determinants of vaccination rates. What about our recommendation? Particularly focusing in the doctors, for example, it's very important to develop medical education programs. It's very important to incorporate the concept of vaccination as a very important prevention cardiovascular strategy, similar to other preventive interventions like smoking cessation or reduction of the cholesterol. Are very important to generate to multimodal intervention, and it's very important to introduce the concept to vaccinate the patients previous or immediately after discharge in persons with acute coronary syndromes. Particularly in patients, it's very important to educate patients and have a strategy to overcome vaccines related hesitancy with simple, truthful, and reliable information. The campaigns are very important, and it's important to adapt it to local and regional needs and use clear, simple, multimodal communication oriented to the target populations. And finally, the context is very important that the different governments include this kind of vaccines as essential medicines, and it's important to guarantee the free provision to target population, for example, in patients with cardiovascular disease. My final message is very important. The implementation is probably one of the most important challenges in the modern medicine, and represent a very complex situation because we have many different barriers and many different dimensions that we can consider. It's very important you can consider in the formula of the success. It's very important to adequate information and innovation to apply an effective implementation, but you need a facilitating context if you want to obtain socially significant results. And obviously, probably at the present time, this is very important to have important skills. And really the 4C represent the most important skill in terms of communication, collaboration, and mainly it's important to have creativity to obtain important results. My final message, ladies and gentlemen, colleagues, is relating to influenza and pneumococcal vaccination. Is really very important to give the people what's worth to everyone who need it. Thank you very much for your attention.
Thank you very much, Dr. Alvaro, for that really insightful presentation. I'm aware that our interpreter, Elise, is working really hard throughout your presentation, and I wonder if you'd like, we might pause for a couple of minutes so that she has a bit of a rest, and we'll come back in about 3 minutes, if that's okay with everyone. Welcome back. And thank you again, Dr. Alvaro, as well as Elise, for your hard work. I have noted various notes and I have a lot of questions in my head already. I think your presentation, Alvaro, is a perfect segue to our panel discussion today. I think I might now introduce our two other panelists before we move on to our panel discussion, and then I'll ask the panelists to turn on their cameras. So our first panelist is Tolu. So Tolu has over 12 years of work experience across the public health sector. She joined the NCD Alliance team in Geneva in 2019 to further develop NCD Alliance strategic relations with the WHO, United Nations agencies, and member state missions. So before joining the NCD Alliance, she worked in both the public and private health sectors in Nigeria. And her most recent role was with the WHO and at the Secretariat of the United Nations Interagency Task Force for Non-Communicable Diseases. Tolu is a pharmacist by training and holds a master's degree in public health from the London School of Hygiene and Tropical Medicine. She also serves on the board of the African Forum for Primary Care. Welcome, Tolu. Next slide, please. Our second panelist is Dr. John Grebenstein, who is a global vaccinologist, a pharmacist, and public health leader. He edits the free weekly newsletter on immunize.org. He was elected to the US National Academy of Medicine in 2021, and he's the 2020 Remington Honor Medalist, American Pharmacy's Honor for Service as a Vaccine Advocate. Welcome, John, and welcome, Alvaro, again. Next slide, please. If you have any questions, please type them in the Q&A box, and I will be monitoring them throughout our panel discussion. Please use the Q&A box instead of the chat function so that it's easier for me to monitor that. If everyone, we've got everyone on the, I've got your video. So I might start, I think Dr. Alvaro presentation was really compelling in terms of, the benefits of vaccinating and the risk if they don't vaccinate, just the alarming rates of AMI and pneumonia and all these other complications and death. So I might start on questions relating to uptake and awareness of the importance of vaccination. So given that vaccination is so important in this high-risk group, I wonder if there's any data in each of your countries, for example, on the current uptake of the recommended vaccine in people living with cardiovascular diseases, and how do you think that compares to the general population? So say, for example, people without cardiovascular diseases. Dr. Alvaro, you've given an amazing presentation. I might give you a bit of a rest. So if John or Tolu, you might want to answer the question first. I think he would really appreciate that.
Sure, I'll jump in. So in the United States, age is a stronger driver to vaccination offering than chronic disease is, unfortunately. In the one slide Professor Alvaro showed, had the United States at 55% of one group for influenza vaccine. That was probably, it was ejection fraction. People with low ejection fraction. That was probably because most of those people were over 65 years of age. If we look at people with heart disease, younger than 65 in the United States, it's maybe 20% vaccinated, 30% vaccinated. And it's primarily because nobody offered the vaccine. Again, to one of Professor Alvaro's slides, the pathology, the immunology is clear, but the anthropology, the medical practice, is what determines the vaccination rate.
Yeah. Tolu, do you have anything to add?
Yes, and if I may come in briefly from the angle of, why we are not seeing many people take up vaccination, and not necessarily from picture from at the country level. I think what we've seen over the past few years is that non-communicable conditions like like the cardiovascular condition we just discussed are on the increase because people are living much longer and not necessarily healthier. And at the same time, while we are seeing that increase in the number of years people have to live, we're also seeing an increase in access to different information. Many of our parents are on WhatsApp groups where one message can reach 1,000 people with just a click. And so we are seeing an increase in people living longer and an increase in access to different information that are not verifiable. And so unfortunately, we're seeing an increase in in vaccine hesitancy, both among people who are well-educated, people who have vaccinated their children, and those who have, very limited understanding of the whole immunization landscape. So one thing that comes to mind when we look at, the current disposition to vaccine is that hesitancy is on the increase because many of our elderly people are exposed to different information that they have no idea whether they are right or not. Thank you.
Yeah, thanks. And Alvaro, do you have anything to add to that, or I could move on to our next question?
No, I'm agree that the more important challenge is what happened in the young people with cardiovascular condition. Is really that the older people represent the people that the majority of the doctors have a clear idea that these people need these kind of vaccines, but the younger people represent a very important challenge, including people with many different risk factors, for example, or cardiovascular condition. But really, for example, in particularly the COVID-19 pandemic represent and express an additional problem, because the social condition that what happened during the pandemic particularly expressed a significant higher the problem was more important during the pandemic because a significant number of patients lost the cardiovascular medication, for example, or don't include the cardiovascular medication. And as I mentioned before, the vaccination rate, including these people in patients older than 65, were extremely low, for example, in Latin America, and really express an additional problem that was the social condition of the pandemic, particularly have a very an additional problem to this situation. And I am agree that the very important point is obviously is the education, but it's very important that the action will be oriented to the particularly population. No, it's very important that you have many different action oriented to the doctor, to the patients, to the constant, to the governments, for example, because the articulation of this action are really very important to obtain a very or more important vaccination rate.
Yeah, I guess building on that, I mean, I don't know what is the situation like in other countries, but in Australia, I think we're pretty good at, the government, health professional organizations, health professionals themselves sharing the same message that, if you are older, you have chronic conditions, you have CVD, immunocompromised and so on, they are at higher risk of severe complications. And so, please vaccinate. How do you think this message is being communicated in other countries that, people with CVD are at higher risk and so they should be vaccinated? Do you think that message is being communicated well enough in your country? I'll start with you, John, again. I'll just go around that circle.
That's fine. So the central messaging, such as comes from the CDC in Atlanta to the United States, or I'm quite familiar with Canada as well, similarly. The national messaging is fine, but it's a local issue. Is somebody saying you should be vaccinated? And that's where the pharmacist comes in, because unfortunately in the United States, the cardiologists do not offer influenza vaccine very often. It is more of a primary care issue or service. And even then, there are many, my wife has had some health problems and has had many outpatient visits, but rarely is she asked about her vaccination status. So the pharmacist is so accessible all around the world that, and there is the value of the pharmacist saying, you're the digoxin user, you're the you're taking medication for your heart rhythm, for your ischemia, for your heart failure. Because I know your medication, I know your risk of infection. And we can keep your heart healthy with this medication and with influenza vaccine or pneumococcal vaccine. And so we are under delivering this very valuable service, but we can fix that.
I really like this last line, that we can fix that. That's a really good sign. Tolu, do you have any thoughts on that?
Yeah, thank you so much. So I really do echo John's points on the fact that we are not optimizing the opportunity to encourage service users who are living with chronic conditions to take up vaccines that can protect them from complicated conditions. For example, in my years of practice as a pharmacist in Nigeria, I don't recall receiving any prescription for vaccination for people living with underlying conditions. And I mean, both practice within the hospital setting and as a community pharmacist, I don't recall seeing any recommendations from a doctor or a cardiologist that this particular patient would benefit from, for example, the influenza vaccine or the pneumococcal conjugate vaccine. And it's interesting because at some point during my practice, I had a chance to undergo a training on how to become a vaccine advocate, and it changed my view completely. So what that made me realize was that we have key opportunities as pharmacists to encourage our patients to be more proactive, to be more health-seeking in their behaviors. And at the end of that training, I think it was coordinated by the American Pharmacist Association, but partnering with an institution in Nigeria. It was, like a 3-day program, like a crash course. By the end of it, we understood the different vaccines available for people, not necessarily the very young that we are familiar with, but people above a certain age that we don't usually propose vaccination to. And so I came out of that meeting feeling really energized to encourage my patients to consider the cervical cancer vaccine, the influenza vaccine, the pneumococcal conjugate vaccine, and a couple of other important ones that are really important to people living with chronic conditions. So, following up on that, I was able to identify patients who needed it. And a couple of them were happy to sort of try it out, in the course of their treatment. So yes, I agree that we are not doing enough in our practice to sort of support the use of vaccination, particularly as we're at a phase where health resources are scarce, and we need to support our health systems to support the growing need for services. So this is a good entry point for pharmacists in particular to put a spotlight on vaccination and encourage people who have critical need to take up that the vaccines that can protect them. Thank you.
Thank you so much for your answers. And I think that really highlights the importance of pharmacists and health professionals' roles on increasing uptake. I guess I have a kind of similar question to Dr. Alvaro, because I was quite shocked to see your slides on the outcomes on in people with community-acquired pneumonia who develop AMI, and they have 4 times higher risk of death in hospital or clinical failures. And with influenza lingering around, I mean, it's really high prevalence currently in Australia because it's winter here. The MI-associated deaths will be even higher. So you mentioned that there are many CVD guidelines that recommend vaccination, but how well do you think this information is being communicated to the public to increase their uptake?
Two comments. The first one, I totally agree the important role the pharmacists of different agents, health agents, in to promote the role of the vaccination in the outpatients. But particularly, I think it's very important to reinforce the idea that for example, the message of the Yami trial, the last trial that I showed you, that expressed the tremendous impact in terms of cardiovascular reduction events in people who receive vaccines in people with acute coronary syndromes, expressed the hospitalization of the acute coronary syndrome, expressed a big opportunity to prescribe immunization. And I think we have a very important responsibility. Our scientific society, the cardiological scientific society, have a very important responsibility to promote this action, particularly during the hospitalization. We have for example, we promote, particularly in our region, the prescription during the hospitalization, because as you well know, all of prescription that you give to the patient during the hospitalization have a very, very important impact in terms of adherence. The adherence from different, for example, in different intervention, when you prescribe this intervention during the hospitalization, the adherence in the first years is very high, including many other intervention, pharmacological intervention. And the influenza vaccination, for example, is a good example of this. And it's very important. I know that the cardiology have a very important resistance to indicate, because they think that it's no problem of the cardiology, that they think that immunization is a problem of the infectologists or pediatrics, but the information is so tremendous, so important, that it is very important that give information to the cardiologists, to the doctors, to the intensivists, that is very important that this intervention will be prescribed during hospitalization. This is it's important we have a very clear message about this, because the impact of the intervention is similar to thrombolytics or PTCA or statins. And it's not admissible that a patient don't receive the indication of prescription of influenza vaccination during an acute myocardial infarction or during an acute coronary syndromes. I think this is a very important message. This is a very important message, an educational message. Obviously, when the patient goes out to the hospital and in the out clinics, the situation is very different. And in this situation, it's very important that many other different health agents and the pharmacists, for example, have a very important role in the prescription or in the monitoring of this situation. But I think that it's very important to reinforce the message that the cardiologists and the intensivists have a big responsibility in this point. This is very important because the results are impressive, really are impressive. When you observe, I don't know, John, what do you think about it? But really, when you observe the meta-analysis and reduction of 50% reduction in mortality, in cardiovascular mortality, it's tremendous.
It's clear. And how long does it take you to get someone to stop smoking? A long time, right? How long does it take you to vaccinate someone? 1 minute.
Yeah, absolutely, it's incredible. It's so, absolutely incredible.
Your points are very clear, and I'll just add the intensity while they're an inpatient. And let me ask you your experience. While the person is an inpatient, there's concern about their stability and how the intensivist is very focused on the patient. They may not want to vaccinate at that moment, but the day before discharge, the day of discharge might be more acceptable to them until they understand all that you know. I don't know. That's been my experience. I don't know if you've seen something similar.
There is other additional interesting observation of the Yami trial. That is, when you observe the curves, after the intervention, you know the intervention was prescribed during the first 72 hours during acute myocardial infarction. But it's incredible that when you observe the curves, the separation of the curves occur immediately
Right.
is very interesting, because
right.
We don't have a clear explanation about that. But when you observe the impact of the intervention is in the first moment. I don't know, really, this is at the present time, there is a big discussion about what is the involved mechanism of this observation, but really represent probably that the immunization have maybe an anti-inflammatory mechanism. Right. We don't know what is the reason, but it's really impressive that you observe that the separation of the curve occurred during the first week when you give the intervention.
Yeah, agree.
I think the cost effectiveness, sorry, if I may just quickly add, I think the cost effectiveness of vaccination as well, when we compare vaccination to smoking cessation, is another major point to emphasize. Many of our vaccines are not patented, many of them are affordable, and so it would really be good to see many more specialists embrace the use of vaccination as a way to protect complications in people that have underlying conditions. Thank you.
Thank you so much, Cholo. I was just going to read out a message in the chat box, which I thought was really nice. So Obina Chukwudibes, sorry if I'm pronouncing your name wrongly, says very true and reflective of the thoughts of most of our physicians to high risk groups vaccination, that vaccines are meant mainly for peds and not their patient class. And thank you greatly, Prof. Liprandi, for lending your strong voice to this call. Very apt. I just felt compelled to read that out. So initially, my next, sorry.
I was just going to comment that.
Yeah, sorry. Go on.
So my experience around the world is that countries get their pediatric vaccination programs in place strongly first, and then from that basis, they then realize they should vaccinate all ages. And so I think that, you know, those of you who don't have a strong adult tradition, the adult vaccination tradition today, can build it over time. But, you know, each journey of 1,000 kilometers, one step each time.
Yeah, that's really true. So initially, my next question was going to ask the panelists what you think are the main barriers for increasing vaccine uptake. But I'll be more interested to know how we can actually increase vaccine uptake. And it looks like from what, John, you said, could we make it like a usual practice when they are, about to be discharged, recommending like for all doctors or pharmacists to recommend that, can we give you an influenza? Do you see that being a common practice in the future? Or is that something that can be implemented now, say, for example?
Yes. Each place where you can catch the patient and tap them or remind them, and the physicians as well, and the nurses, the whole team, the better. So upon discharge, what are your standing orders for discharge? I'm sure the myocardial infarction patients at discharge have a list of things that they should do, or the heart failure patients, or the diabetics, or people with chronic obstructive pulmonary disease. If you can get the vaccines onto those lists at discharge, that helps. And then in the outpatient setting, in the ambulatory care setting, when they come in with new prescriptions, they're open to new, I'm starting something, you can offer the vaccine then. The most important thing is to offer the vaccine. If you don't offer it, they can't accept it.
That's a really good point. And Cholo, I wonder what your thoughts are. So I was watching the previous FIP digital event on vaccines and chronic respiratory conditions, and I was quite taken aback that in many countries, I think including in Spain, pharmacists are not allowed to vaccinate. Do you think that, you're not allowed to vaccinate, you don't have vaccines in your pharmacy, you probably won't think to offer to the patients? So do you think that that's a barrier as a pharmacist for patients getting timely access to vaccination, or even being offered the opportunity to be asked?
I think that the fact that not all pharmacists globally can actually administer vaccines continues to be a significant barrier. I hope that, I haven't gone through the COVID-19 pandemic and seeing the need to roll out vaccines rapidly, and the role that pharmacists have played in some countries. I hope that this is a learning point for policymakers on how important pharmacists can be as, pick-up points for vaccination. So I agree that that's a barrier, but I also think that even though these barriers exist in different countries, pharmacists have a critical role, continue to have a critical role to play in promoting the uptake of vaccines amongst the populations they serve. Like I said earlier, sometimes it's even as bad as the fact that governments do not have policies that support the life course approach to vaccination, meaning that some countries focus on just early childhood, and that's where it stops. But we as pharmacists, we have the opportunity to learn more about how we can protect different ages across the life course, from preventable infection through vaccination. And we have the opportunity to advocate for these things in our engagement with them, from day to day in the course of our practice. And, if you want to take a step back and look at some of the things that are, some of the ways we can address limited access or limited uptake of vaccines, we can look at the system level issues. And some countries don't have policies, like I said, that cover the life course. Some countries have some vaccines that are covered under universal health coverage, while some others have to be procured through, out-of-pocket payments. So these are some of the things we can advocate for. We want to see government putting all vaccines that can prevent diseases in their packages, and making sure that people can access them at no cost. These are some of the things we can do to address the barriers to vaccination in countries. Thank you.
Thank you so much. And just to add that, sharing from our experience in Australia, end of last year, I think Australia, only about 15% of COVID vaccination were administered by pharmacists, but now it's up to like 45%. So we are almost half of the vaccinations are being administered by pharmacists. And I think that's hopefully something that other countries, will have more confidence that pharmacists, we are trained and skilled to administer vaccines. The other thing that Professor Alvaro, you shared, the 4 C's to success in the 21st century. And these are skills that I'm also needing to learn. So communication, collaboration, critical thinking, and creativity. But I also remember with vaccine hesitancy, we also have 3 C's, which is confidence, complacency, and convenience. So that kind of sparked an idea and I've got 3 different questions on that. Might ask each of you to answer one of those if you like, or you want one person can answer all of them, up to you. I might start with confidence. So what are your thoughts on public confidence on the safety and efficacy of vaccines, and whether people with CVD, given that they have more, high risk of complications, they might think that, they are more susceptible to the adverse effects of vaccines and hence hesitant to get the vaccine? I see, John, you're muted, so I'll ask you first.
Most people are confident in vaccines, and there are a few people who are doubters, let's call them, or misinformed. So we can help with the education. We can help reassure. It's important for the pharmacist, for the physician, for the nurse to be confident himself, herself, themselves, because that will be obvious as we work with the patients. But heart disease patients should be looking for help and willing to accept the help. And so I think Professor Alvaro showed the slide of when the physician was the word on the slide, but when the provider of whatever profession recommends the vaccine, the people are highly likely to accept it.
Really, the responsibility of the doctor is absolutely important, but is undeniable. There are many other factors. I totally agree that guarantee the access is a primary step. As I mentioned before, for example, in my region in Latin America, the vaccines are considered essential medicine in less than the 40% of the countries. This represents that in these countries, the access to the vaccines are not free. And the access and the cost represent a very important barriers in many countries in Latin America, for example. And this is a very important aspect. It's very important that our action are oriented to the government to guarantee the free access to these kind of vaccines, particularly in target population. And other important point are the education of the population, or the message, how we perform the message, how we perform the message to guarantee the confidence of the population in this message. Because one important point is the trust, no? How the patient trust in our information. Because as you well know, there is many groups anti-vaccines, no? That there are many, it's very interesting. There are many papers in the literature that clearly express, for example, that one fake news may be to impact in impressive form in contraposition with the scientific information. It's incredible, but it's the truth. And it's very important we establish a bridge of communication with this kind of group, with the anti-vaccine groups. It's our responsibility to discuss with them and to explain and give information. But as I mentioned before too, it's very important that our organization, it's not only responsibility of the government, the campaigns. I think this is an important message too, because, for example, our scientific organization have a big responsibility in this point. And really, we began to make a way in this point. Really, our experience in campaigns, we don't have a long time experience, but really in the last 4 or 5 years, every year we made a campaign related to give information to the population. And we learned very important message that first one, the message will be oriented to the target population. For example, in our case, in the American Society of Cardiology, our target population is people who living with cardiovascular disease. And it's very important that the message goes to these people, particularly to these people. And for example, we learned that for example, the campaign, the multiple voices are more, is probably that we heard more than one voice. And for example, we chose one day, for example, the World Heart Day in September 29, we chose this day to give the same, we have the same slogan. For example, last year we used the same slogan, more than 16 countries, more than 100 institutions, and 60 cities in America have the same slogan at the same time with the same words. And I think it's very important that we share this information and goes together. No, this is very, very important. Just a message is that the campaign are not only responsibility for the governments. And my message is that in our societies and our organization have a very big, important responsibility in this point. Thank you.
Mm-hmm. If I may add just brief points to all the wonderful comments that have already been shared. I think that, again, the ongoing COVID-19 pandemic is a reminder of how strong vaccine hesitancy is among us. We saw heads of government coming out to deny, the role that vaccination could play in ending the pandemic. We saw sport icons coming out to take a stance that, we never imagined they could take. So, and we've seen how all these have influenced the divide we have between those who are pro-vaccine and those who are not. And I think, again, like it has been shared, we all have a role to play in making sure that people who are particularly high risk can access the vaccines they need to help them live a better and longer life. One of the things I noted is the fact that we should aim for a dialogue based approach. We shouldn't just aim to dump information and go. We should get to a point where we, understand why people are holding back. Are there fears around safety? Are there fears around where they can get the vaccines? Are there fears around adverse events, and how, these will impact on the conditions they're already living with? And we should then take it a step further by addressing these fears for them and making sure they're at a point where they feel comfortable to take up the vaccines. Reminders, even for health workers and for service users, could also play a critical role, making sure our systems can support, reminders for the annual, for example, the influenza vaccine, the annual pneumococcal conjugate vaccine could also be a way to help everyone stay on top of, tracking uptake of vaccination. So yeah, there's a role for us to play, and yeah, thank you.
Thank you so much. And I'm smiling here because my other 2 C's on complacency was going to ask Professor Alvaro about how can we better convey message. And my last question on convenience was going to talk about affordability, accessibility, which Tolu has already answered that question. So I know that I also realized that we're running out of time a bit. So I might move on to the last kind of bit because I guess next set of questions will be a bit more pharmacy focused, given that our target audience today, quite a few of them are pharmacists. So I might start off with you again, Tolu. As a pharmacist, what do you think are the strategies? I know you've mentioned a few, but specifically for pharmacists, what do you think are the strategies that we can use to promote vaccination in this particular group of people with cardiovascular diseases?
Thank you so much for that. I think the first thing is to make sure that all pharmacists understand the role that prevention through immunization can play, in protecting the populations we serve. Like I said, I don't recall receiving any formal training during my years at school on vaccinations, particularly for older people. But we are now at a phase where we understand that the life course approach to immunization is critical. So it will be important for our curriculums to cover going forward the role that immunization can play for the populations we serve. And so this might entail some of us going back to the classroom, going back to training rooms to learn more about the different options that are available for the populations we serve, and understanding how we can best get them, to them in the course of our treatment. I think pharmacists can also play a critical role in calling on governments to expand the immunization programs at the country level. Many of them are still focused on early childhood, but as we've seen now, there are huge benefits across the life course, from vaccination. So we can play, a critical role in engaging governments to ensure that immunization plans are expanded to cover products that can protect people across the life course. And closely linked to that is the fact that these vaccines have to be affordable and accessible to the people we serve. So putting systems in place that ensure, supply chains are, reliable all through the year, and making sure and ensuring that people can buy these things, can pick them up rapidly when they come into, our consultation rooms to seek for care. So those are some of the few points that come to me right now. Thank you.
Those are very wonderful suggestions. I might pose the same question to you, John, but I would also be interested in your view as the Director of Scientific Communications at Immunize.org. I know FIP has a handbook for vaccination, but if you would have any other strategies or tools or resources that you would share that pharmacists can use.
Yeah, so first, everything Tolu said is correct. And I'll just comment that every pharmacist around the globe can have a role. Maybe your country doesn't let you administer vaccines, or you haven't been trained personally, but you can educate and you can put up signs and you can put little pieces of paper, little flyers into prescription bags, or put little stickers on the heart disease medications, on the vial that says influenza vaccine is good. Influenza vaccine can help you. And very simple, low tech, low cost messaging, even low cost of your labor. If you're in a very, very busy pharmacy, filling many prescriptions, there are ways to do this that don't take a lot of your personal time, or using the clerks and the technicians and the support staff that you might have available to you to be on the lookout for patients taking these medications and remind them, tap them on the shoulder, say one sentence, think about flu vaccine. I recommend flu vaccine, very helpful. Immunize.org is obviously a website, but it's also the name of a group that prepares a variety of educational materials for people who vaccinate. Physician office teams, health departments, vaccination clinics, pharmacists. Most of the materials are in English. I apologize for those who need it in more languages, but many of the information sheets have been translated. Just the basic instruction sheets have been translated into 46 or 47 languages. So some materials are available that would hopefully help you where you are. But they're very practical, how to organize your workflow, how to explain the need to vaccines to people. And, if it's not in the language you need, you can, maybe engage someone to help and to translate. But they're meant to be very practical materials for people, for busy vaccinators.
Thank you. Yeah.
Brief
Go ahead.
Yeah. I totally agree that the crucial role of the pharmacists in giving information to the patients, particularly the outpatients. And I think I have a suggestion, that maybe for example, I want to share our experience, as I mentioned before, because, for example, when you decide from our society to make a campaign together, we obtained really very important, the success was very important, and maybe will be a good idea that the information don't express an individual position of the pharmacist. Maybe, for example, you have to take the same idea and have during one day all over the world, all the pharmacists, for example, I don't know if it's possible, but you have an action that will be run together in different parts of the world through, for example, the main organization. This is the history of our organization too. For example, no, in the past we have individual effort, and after that, 6 years ago, we decided to work together with the same organization, with the same day, only day, or we share this initiative in different parts. And I mentioned before, when many people say at the same moment the same slogan, it's possible that the message will be delivered in very important form. No? Sorry. Thank you.
Thank you. Thank you so much. There is finally one question on the Q&A box, so I think I might ask that. So it's a question by Dr. Timmy Purr. Thank you for the question. Said, I don't recall receiving any training on vaccine in school. Does it mean it's different over there? I don't know if any of the panelists would like to comment on what sort of training students get in.
In the United States, the program is now incorporated into essentially every college of pharmacy, into the basic curriculum. Tola mentioned a program that the American Pharmacists Association developed. I actually helped write it back in 1996. That runs for about 2.5 days. It's an additional skill. It's about 12 hours of classroom training and then 8 hours of practical training and injection technique and those sorts of things. FIP has offered this in several places around the world, it's a skill. Even without that formal program, you could join a vaccination clinic for a week or two, or some period of time to learn the practical issues. So there's a variety of ways to, if you didn't get it in your main schooling, there's ways to add it on pretty quickly. Tolu, if you want to add.
Yeah, I'm just so thankful that you're part of those who sort of developed the module, because at the end of those 3 days, I felt really ready to begin to talk more confidently about vaccination. And I think it helped my practice, both in the quality of care that we're able to provide to service users at that time. And so, yes, I don't recall receiving any formal training within the four walls of a school, but I'm happy that I found the opportunity of that training in 2012, actually, and it helped to sort of boost my confidence in how vaccines can protect people living with chronic conditions in particular. So, Dr. Timipre, look out for trainings in your community. You may need to flag it with maybe the bodies that you work with. If you're in Nigeria, perhaps the community pharmacist body may want to bring that back again, because as at that time, it was organized by the community pharmacists in Nigeria, and it was a really useful opportunity for me back then. You may also want to flag it with the Pharmacist Society of Nigeria. If you're currently in Nigeria, they may wish to bring that back for those who are interested within the country. Thank you so much.
Thank you so much. I just realized that we're almost 90 minutes up. So I might ask one last question to all the panelists. So what would be your, I guess, one or two key messages out of today's session, or action points that you would like to share with the audience today to address this whole, suboptimal vaccination problem and all that in this particular group of people with cardiovascular diseases? I might start with you, Professor Alvaro, if you don't mind.
Well, final message is it's very important to remind that this intervention, particularly this intervention, the immunization with influenza vaccines or pneumococcal vaccines, are considered for people who live with cardiovascular disease, represent an intervention with a result that is very similar to other intervention that we really apply in our clinical practice. It's important to remind that particularly influenza vaccination and pneumococcal vaccination are considered a very, very important prevention, very, very important strategy in terms of cardiovascular prevention, with similar results with the absolutely common or frequent other kind of intervention. And it's very important that all the different agents of health agents, including pharmacists, doctors, nurses, come together or work together with this to give this measure to our colleagues in the first time, and in the second place, to work together to give this important message to our patients. Because, as I mentioned before, the final message is it's important to give to the people what was they needed, really. And this is my final message. Thank you.
Thank you so much. John, do you want to go next?
So vaccination is a gift of love. It's a gift of life. So start with the people you love. So some of the people on watching have heart disease themselves, or their parents do, or their family members do, their grandparents maybe. So get the vaccine for the people you love most first, and then work out to the whole rest of your patient population. But it's a very personal matter, and I used to say that I wanted my children's grandparents. I wanted my children to have as many years with their grandparents as possible, And so vaccination gives you more years for the children to have with their grandparents.
Really good, really nice message. Totally do. Yeah, your key message.
So I want us all to leave this meeting knowing that people living with underlying conditions, particularly cardiovascular conditions, are at increased risk of severe illness and death when they're exposed to infections that can be prevented through vaccines. So vaccination it makes economic sense, it makes health sense, it makes all the sense in the world, and we should prioritize it in our engagement with people living with underlying conditions like cardiovascular conditions. Thank you.
Well, thank you so much to all the panelists. It's almost midnight here, but I think that I'm getting more and more awake from all these provoking thoughts, and I may have also nicked a few ideas that I think can be easily implemented, really quick wins here in Australia. Thank you, everyone. I have learned a lot, and I would sincerely like to thank our speaker, panelists, and also our interpreter and everyone at FIP. We will now wrap up, and I think I have a few more slides to show. Next slide, please. So we are very excited to invite you to the 80th FIP World Congress of Pharmacy and Pharmaceutical Sciences in Seville in Spain. Finally, after a few years, everyone can meet physically. It will take place from the 18th to 22nd of September, and the theme this year is Pharmacy United in the Recovering of Healthcare. Registration and abstract submission are open, and so for more information, check out our website at seville2022.fip.org. These are the 3 key programs. So topic 1, never waste a crisis, learnings for future preparedness. Topic 2, science and evidence supporting response to COVID-19. And topic 3, on dealing with new and extraordinary ethical challenges. And also, next slide. If you would like to check out all our future FIP digital events, you can find more information on upcoming events at events.fip.org. So thank you very much, everyone, and I hope you enjoy the rest of your evening. Thank you.